Hi, I'm Graham Tyson.
Edward Tarnawa, welcome to another edition of Tea Time. It's been a minute. We are the docs here in what we call PREG Low Country. We got offices in Somerville and Mount Pleasant.
Yep. And we're here today to answer all of your infertility related questions. We've got some excellent questions from users today that we'd like to dive right into. So let's get started.
Let's do it.
All right. So let's jump right into our questions. I guess I'll take the first one and I'll read it off here. So one of the users asked, what are the success rates of timed intercourse, IUI, and IVF with someone specifically that has endometriosis? So I say to my patients a lot that we really don't have that many tricks in our bag when we're talking about fertility, what we do. So we have IUIs, we have timed intercourse cycles, and we have IVF. Now there's a lot of stuff that goes in between there, but when it comes to actual fertility treatments, this user hit the nail on the head. These are the things that we mostly offer people in order to help them, achieve pregnancy. So when I talk about endometriosis, what I typically tend to say is that we don't have specific numbers about what endometriosis does to a specific chance of success in fertility. We know that if someone has severe endometriosis, that more than likely something like timed intercourse is not going to be a good choice for you, because whether you have endometriosis or not, the chances are probably not very good. If you have unexplained infertility with or without endometriosis, doing timed intercourse is going to change your rate of success per cycle from about 4% up to maybe like 6 to 8%. And so with endometriosis, if you add that to the mix, there's a good chance that's going to sort of knock that chances down a little bit, but the chances already weren't that great if you have unexplained infertility with or without endometriosis. So with an IUI, this is what we would offer often to couples who have unexplained infertility. If you have no endometriosis going on, I usually quote a number of about 15% per cycle. And so I usually tell couples, let's try it maybe 3 times. After 3 times, you add 15 plus 15 plus 15, so 45%. Close to half of couples will get pregnant with 3 IUIs. The data really tells us that with someone who has endometriosis, that chance is a little bit less per cycle, so maybe like 10% per cycle. So you think about, instead of 50% of people getting pregnant with 3 cycles of IUI, looking at maybe 30%. So it doesn't mean that you can't get pregnant with an IUI, but it takes that chance down a little bit, because we know there are things going on with endometriosis, like inflammatory issues, things that we just don't know as much as we'd like to yet about it, but we know there's a negative impact. With IVF, that's going to be, as with any infertility diagnosis, your most effective way to get pregnant. But we still say that there's probably some decrease in chance of pregnancy per embryo transfer. And what I usually quote people is around 10%. So if you take a couple's factors, and you figure out what their chance of pregnancy is, whatever that is, let's say it's 50% per embryo transfer, I usually sort of cut that down by about 10%. Now, it's not the most scientific way to look at that, but it does tend to sort of pan out. And so I think the short version is, we don't know as much as we'd like to about what endometriosis does. We know that it affects the chances in a negative way, but we know that people with endometriosis can definitely still get pregnant. And so I would say, bottom line, don't start with timed intercourse if you have endometriosis. IUI would be fine. Best bet would probably be IVF.
Yeah, endometriosis, it's tricky. There are some who will never have any issues with achieving pregnancy. Endometriosis has many, many flavors along a spectrum. It can be mild, it can be suspected, it can be known severe with tons of operations in the past. All of those are going to influence our counseling for an individual patient. But assuming all options are on the table, like Dr. T here said, IVF is always going to be the most efficient, most effective, but there's room for other options. What are our opinions on restorative reproductive medicine, and is that an option at PREG? Restorative reproductive medicine, it's not a medical specialty, it's an ideology, all right? It's driven by philosophical and oftentimes religious beliefs for groups who are opposed to IVF and related treatments. And that's unfortunate, because I think patients with infertility, with recurrent miscarriage, they're in a vulnerable population, right? They want help, they want answers, and they come to us, you come to us for evidence-based, thoughtful, effective treatment. And that's our job as physicians to ethically provide. Mm-hmm. And there's groups out there who are opposed to IVF for various reasons. That would be a whole other talk to counter each one of those. But for groups to come out and say, forget evidence-based, effective fertility treatment and come to our center offer restorative reproductive medicine is predatory behavior. It's misleading and it's preying on a vulnerable population. They claim that we as fertility doctors just treat the symptoms, right? We put a Band-Aid on the treatment, which is wrong. The essence of reproductive medicine is thorough evaluation first, right? Restorative reproductive medicine, they claim that they focus on the root causes of infertility, and by doing that, they can avoid effective fertility treatment. But that is a fallacy. That is a misleading, predatory statement. Of course, we're going to evaluate to identify root causes. Ideally, take simpler way forwards. But in those in whom IVF is all that can be effective, or is clearly the most effective option, telling someone that shouldn't be considered is just awful, in my opinion. So I encourage anyone to steer clear from those who say that they offer restorative reproductive medicine. And the short answer is, yeah, we offer that. We offer effective treatment, and we're going to evaluate from the ground up. We're going to look into every single potential cause and come up with you for a treatment plan that's right.
Yeah, and we see patients all the time that have various religious or philosophical reasons where they may not necessarily want to do IVF.
Sure.
Or they just, for instance, I had a patient just a little while ago that, needed IVF but didn't want to have more embryos than they could transfer. There's ways that we can do that.
Absolutely.
Right?
There's options, and the right way is to consider all options. And there's various factors that go into weighing how they compare against one or another, but dissuading someone from even considering effective, proven, medically sound fertility treatment, I'm disappointed that there's groups out there like that.
Yeah, I would agree, and it leads to a lot of unnecessary struggle and a lot of unnecessary time to when a patient may finally get to real effective treatment.
We encourage you to go to ASRM's website, the American Society for Reproductive Medicine. They have a really nice policy statement on their thoughts, our thoughts on those who offer what they call restorative reproductive medicine. It's unfair, it's misleading. We don't want that. Come talk to us, and we'll have a candid, honest discussion on your history, proper evaluation, and what your options are.
Okay, I'll take the next question. What are some things that would make us expect endometriosis, specifically silent endometriosis? So this is an interesting question. There was a study that looked at women that had unexplained infertility. So unexplained infertility basically means that we go through a full workup, our basic workup for infertility, and everything looks normal, right? So sperm looks normal, the person is ovulating, ovarian reserve looks normal, periods are essentially normal as well. Everything looks like it should be functioning. Tubes are open. Do an HSG and make sure the tubes are open. So you do all that stuff, and yet the couple is still not conceiving. So that's unexplained infertility. And in these particular set of patients in this study, these patients were not having particularly painful periods, which is really a hallmark of what I typically would expect for endometriosis. And in these women, the study was basically looking to say, okay, if we put a camera into these people for a laparoscopy and look, do they have endometriosis? And it turned out that about 40% of women with normal periods but unexplained infertility actually had some degree of endometriosis. So the first part of the question is, I think just having infertility raises a red flag for me that there might be a little bit of endometriosis going. I mean, if you think about it, 40% is basically a coin toss. But there's another side to this question too, which is, do we need to do that? Do we actually need to look and see? And the answer is no. In general, the studies are quite clear that doing a procedure specifically to put a camera into the stomach and look for endometriosis is not necessary in a person that has unexplained infertility, because it doesn't really change what you're going to do for them. In general, with or without endometriosis, the basic treatments will still work. We talked just a second ago in the previous question about, what are the effectivenesses of IUIs and IVF. The truth is they're still both effective, and there is a small hit that you might take. But the thing is there's nothing that you're going to do knowing about endometriosis or not that's going to change what you would do. You would still offer IUI, you would still offer IVF. And so while I do think that just having infertility makes me think, yeah, there's a possibility that there might be some underlying endometriosis, I don't think we necessarily need to go looking for it every time. Now, on the other hand, if you have extremely painful periods, if you have symptoms, pain with intercourse, pain using the bathroom, those things may be situations where you can actually treat the endometriosis and treat the symptoms of it. And that's a situation where doing surgery for that purpose might be worthwhile. But just for the purpose of going to look, do I have endometriosis or not, in the setting of just unexplained infertility and no symptoms of endometriosis, it's not necessarily worth looking. And I think the data is pretty clear to back that up.
Yeah, when it comes to endometriosis, it's important to clarify what the goals are. If the goal is pain management, if somebody has disabling pain, they're missing work, missing school, that needs to be addressed. That becomes an important priority. And surgery, proper, thorough, complete surgical excision in the proper hands, that is the most effective treatment for that. Whereas if the goal is pregnancy, it's dedicated fertility treatment. Sometimes there's room for both. The ovarian reserve status could influence that, right? If someone is young, very, very reassuring ovarian reserve, we're not worried about egg supply, if you will, there could very well be plenty of room, plenty of time to go ahead and address the quality of life issue surgically, and then refocus on achieving pregnancy. So we don't go look for silent endometriosis. It's okay to assume if it's there, it's not going to change the direction that we go.
Yeah.
Here's an interesting question. Explain epigenetics regarding donor
That's a good one.
eggs.
Yeah.
That's a interesting question. It's a complex one, and I'm no epigeneticist.
Me neither.
But that word does mean something to me, and I think it's important for those who are considering donor egg IVF to understand. Donor egg IVF, I would argue it's the most effective treatment that we have at any age group. So for those who have a suboptimal, or let's say a poor, even futile prognosis with IVF, with their own eggs or other types of fertility treatments, this is an extremely effective option. It's a very different option though, right? And some people struggle with the concept of donation of eggs from another individual to create embryos with either donor sperm or their partner's sperm and then to achieve pregnancy. And some ask, will I, if I achieve pregnancy via donor egg IVF, will I have any genetic link to the child?
Yeah.
Genetics is not as straightforward, certainly not as simplistic as a lot of people might think, right? We all have the same genes. They're all spelled the same way. If we didn't, that's a mutation, right? Yet we're all different. How in the world can that be? And that's because genes are not it's not a template that goes into a machine and the same output comes out every time, right? There's tons of regulation on how genes are expressed, turned on, turned off, regulated throughout life. And it's how those genes are expressed that gives us genetic variability in life, right? So imagine an embryo is created through IVF, donor egg IVF, any kind of IVF. If I transfer that embryo to somebody versus that embryo to somebody else, there will be differences in that child, right? Maybe not in terms of physical characteristics or things like that, but in terms of their personality, their intellectual ability, health. Those things are influenced by other factors, and a big one is environment, okay? And that's the essence of epigenetics, is how does environment impact gene expression? And so the mother, the patient, right, who receives the embryo through embryo transfer, that's the environment that embryo, that person is going to be influenced by. That's their environment that will have all sorts of impact on their genetics, how their genes are expressed. So I argue that via epigenetics, the person, the woman, the patient is going to have all kinds of genetic influence on their child. And that's a high level discussion, and I encourage anybody who's been thinking about donor IVF that might have some concerns about it or related worries about genetics to come talk to us, because there are lots of layers to this that might not be immediately apparent, and it deserves careful and understanding discussion.
Yeah, agreed. I would say that, when you think about sort of the broad spectrum of our genome, I always tell people when they're considering, because as Dr. Tarnawa said, people have to come to this in their own way. It can be a challenging thing to think about using someone else's eggs, and then carrying that pregnancy, and people think like, well, how will I feel about this pregnancy? And one of the things I talk about all the time is that most of our DNA, 99.9% of it, is exactly the same. The very small amount that changes from person to person is it's just like this tiny little wisp, and so the most important thing about being the parent to a child is being their parent. And whether you share like this tiny little wisp or not is not the most important thing. I don't think there's any child out there that will ask, well, did this come from your egg or not? They don't care. They see you and they say, Mom, and that's the most important thing. You are their mom, you are their dad, and that is something that will never change. And so, as Dr. Tarnawa said, someone carrying that pregnancy has all that influence during gestation, and then all the influence for the rest of that kid's life. And that's what being a parent and being a mom and a dad, that's what it's all about.
Sure.
All right, so we got one more question here. What are nutrition steps for both the partners to take before and during IVF? So when I talk about nutrition with my patients, this is something that I kind of got from my boss. It went back from when I was in training, is you got to keep it simple. You don't have to go crazy with a million different supplements and all these various things. It's pretty clear that the basic vitamins and minerals that you get from a multivitamin, prenatal vitamin ideally, and a healthy diet are going to give you everything you need. But there are a few things that you can think about when you're trying to specify, okay, well, I just want to know exactly what I should be doing. So here's what I always tell my patients. When you're in the midst of doing an IVF cycle, or really any type of infertility treatment at all, here's what I always say. If you take your macros, your carbs, fats, and proteins, you want to, and if this is them all in a line, you want to have carbs be less, but not zero, so no keto diets. You want to have less carbs, and when you want your ratio of fats and proteins to be higher. Healthy fats, healthy proteins, eggs, avocados, things like that, okay? Very simple. What does this do? Well, the cutting down on your carbs is going to keep you from having insulin spikes. We know that there are insulin receptors and IGF receptors, insulin-like growth factor receptors in the ovaries, where if you have spikes in insulin, it can have an effect on your ability to create a dominant follicle and help it to grow. So by decreasing your carbs, increasing your fats and proteins, that's going to help that. Second thing that I always think of is, what are our hormones built on? They're built on cholesterol. Where do we get cholesterol from? Healthy fats, right? So you're giving yourself the building blocks to make those hormones. The other things you can do to sort of just help things, this is especially true for our patients that have PCOS. I see this a lot in people that work in healthcare, people that skip meals. I do that all the time. So this is like a, do as I say, not as I do sort of thing. So don't skip meals. You want to be getting 3 meals a day. Don't ever skip breakfast. Start with a good healthy egg, an avocado toast. Get lunch, get dinner, and try your best not to snack during the day. 3 healthy meals a day. That, once again, keeps you from having those insulin spikes. And again, especially for people with PCOS, that can be really helpful, actually. I've actually seen some patients in the past who had a lot of trouble getting a dominant follicle with our typical treatments. We really sat down and talked about what their diet looked like, a lot about skipping meals, things like that, and lo and behold, the medicine actually works, and we saw a good dominant follicle grow. In specific patient populations, starting again with PCOS, one of the things that's been shown to be helpful as far as supplements is inositol. It's a kind of annoying thing to have to take because it's a powder form, but it has actually been shown to be helpful. And then the last patient population that has a specific benefit would be people who have diminished ovarian reserve. So those are women whose AMHs are on the low side. Studies have shown that CoQ10 is helpful for those women. And you want to get more than what you typically would if you're just taking it as like a daily sort of multivitamin. You want to be getting about 600 milligrams a day. That's what you're looking at. So outside of that, getting your normal levels of calcium, like 1,000 milligrams. You want to get vitamin D. I think it's like 800 IUs of that. And then getting sort of just everything you get in a prenatal vitamin. Last thing, if you're planning on doing an embryo transfer sometime, or if you're doing an IUI cycle where you may be pregnant soon, you want to make sure that you're getting 400 micrograms of folic acid. That's not as important for helping you to get pregnant, but we store folic acid. So once you are pregnant, folic acid is what's used by their babies to sort of build their backbone and sort of the tissue that around and supporting the spine. And we know that if women have low folic acid levels, that leads to neural tube defects. And so you want to be getting those tanks full so that when the treatment finally works and you are pregnant, the baby has everything it needs to sort of knit that backbone together so you don't end up with problems as far as neural tube defects and other things like that.
And one other thought on diet. As Dr. Theisen said, there's no one diet that we can endorse. It's a healthy balance, healthy lifestyle. Of course, exercise and healthy living in general is going to be important, but avoid extremes. Lots and lots of people come in and ask, should I fast? That's extreme, right? And there are a few conditions in humanity that will lead to a rapid shutdown in human fertility. Wartime famine, things like that, right? I mean, that will do it. And anybody who fasts, that's going to lead to major disruptions, abrupt changes in the body's metabolism, and not ideal for those who are trying to become pregnant. So I'm well aware that that's a popular fad out there, and plenty of videos to go watch about it. But in no way do I recommend fasting when we're trying to achieve pregnancy.
Keep it simple: 3 healthy meals a day, healthy diet, as sort of just defined just now, and that's all you really need. You don't have to worry. That's one thing you don't have to worry too much about. As long as you're sort of keeping your healthy diet and not skipping too many meals, you should be good to go.
Here's a question, pretty common one that we get: is Lovenox recommended for unexplained recurrent pregnancy loss? We talked about vulnerable populations before.
Yeah.
Those with recurrent miscarriage, I consider one. It's a really rough situation to be in. It's heartbreaking. Desperation is understandable, and usually if someone were to say, I have a treatment or a test that's going to be effective, those with recurrent miscarriage are going to jump all over it. But there is an evidence-based approach to the evaluation of recurrent miscarriage that needs to be adhered to, right? Looking for conditions that are without question associated with recurrent pregnancy loss, but also have effective treatments. People's minds often go to blood clotting, what we call thrombophilias, and it's, I guess, kind of easy to try to connect dots between disorders there and pregnancy loss, and so they ask about Lovenox. Lovenox is a blood thinner and safe medication when used at what's called a prophylactic dose. But unfortunately, there's not an easy answer here that's going to make a lot of people looking for answers happy. This has been studied ad nauseum in terms of looking for increased prevalences of these thrombophilias in those with recurrent miscarriage, and treatment with low-dose blood thinners like Lovenox or heparin. And there's just not been shown to be any benefit, especially with what we call empiric use, or using it just because. So that is not in my standard toolbox for those with recurrent miscarriage. Now, we've all had very unique, or patients with very unique, oftentimes dramatic histories, and there's times when perhaps we can try something a little bit outside the box. So if anybody listening has said, wait, he's given me Lovenox before, but there can be a time and a place. That's the art of what we do, when we can try something that's not necessarily part of the
letter of the law,
the usual approach. But in general, I think the answer to the question is no. Lovenox is not recommended by us or the American Society of Reproductive Medicine CHEST guidelines or the American College of OBGYN.
Yeah.
Fair enough?
I would agree with that, yeah. All right, well, that's all of our questions for today. Again, excellent questions from the users. Please keep them coming. We love answering your questions, and you guys come up with amazing questions. So send them our way. We will get to them as fast as we can. And thanks again. Yeah, we need to do it again soon. It's fun, right? I love it. But special announcement, right now, tea time is 2. Soon it will be 3. We will have a new doc joining us in the very near future, also with the name of T. Yeah, so, triple T. Yeah, so... We'll either have to come up with a new name or get some more chairs or both. But look forward to that. We'll have more specifics and a very special announcement coming soon. Yeah.